Well, welcome everyone. My name is Chuck Kahn. I'm a radiologist at University of Pennsylvania, and I have the pleasure of serving as chair of RSNA's Radiology Informatics Committee. And you're going to hear from a number of folks this evening who have been involved in organizing this year's challenge. I just wanted to say on behalf of all of us involved in the informatics activities for RSNA, how important this activity is and how much we really value all the work that's been done. It's been a tremendous effort, and it's going to have great scientific and educational benefits for all the members in RSNA. So thank you all very much.
Hello, everyone. I'm John Mongan. I'm a radiologist at UC San Francisco, and I'm incoming chair of the RSNA Machine Learning Subcommittee. There's a lot of work that goes in behind the scenes to making an event like this happen. I just wanted to take a couple of minutes here to recognize some of the people who've done some of that work. First, the RSNA Machine Learning Subcommittee. And these are the people who serve on this committee, does a lot of work behind the scenes. And I unfortunately don't have time to go into the individual contributions that each of these members has made. But I do want to recognize the leadership of Dr. Luciano Prevedello, who's been leading the subcommittee for the last several years. Really a dedicated and skillful leadership that I don't think this challenge or any of the previous challenges would have happened without his leadership. And I want to recognize and thank him for that. Additionally, we had a task force that was devoted specifically to organizing and running this challenge, which included many of the members of the Machine Learning Subcommittee, as well as representatives from the Society of Thoracic Radiology, Stephen Hobbs and Carol Wu, and some additional members who assisted with many of the important tasks of organizing this. And then I also want to recognize our very dedicated and hardworking RSNA and Kaggle staff, Chris Carr and Jamie Dolkowski from RSNA, and Julie Elliott and Phil Kuliton from Kaggle, who made sure that nothing fell through the cracks and kept all of the butterflies flying in the same direction. So again, really thank you to everyone who contributed to making this possible. Hundreds of hours of work behind the scenes went into this, and I'm very grateful for everyone's contributions.
Thank you, John. Hi, I'm George Shee from Weill Cornell Medicine. I'm here to acknowledge the all-important data collection efforts. This year, we were able to collect data from around the world, 5 sites from 5 different countries representing 4 continents. It was a really big effort, as you might imagine, and the people listed here made it possible to get data for the Machine Learning Challenge. And from each site, there were lots of other people involved for data collection and de-identification. Here are my disclosures. So in this data set that we're calling the RSNA Pulmonary Embolism CT dataset, or RESPECT, there are over 12,000 chest CTs and over 3 million images. For various reasons, we only used a subset of the total, about 9,400 exams and 2.3 million images, for the challenge. We are working on releasing the remainder of the exams, and we'll be posting this complete data set on the RSNA website soon. Stephen Hobbs, who will speak next, will go into details around the massive annotation efforts. But just to briefly show you, here are the labels that we used. Essentially, the presence of PE was annotated at the image level, and the rest of the labels were annotated at the exam level. Most were annotated by a single radiologist, but about 20% of the exams were annotated by 3 expert chest radiologists, which were used for the test set. A quick word on de-identification. Here are the list of tags from the DICOM images that were kept. So instead of removing certain tags, we came up with a list to keep and then deleted everything else. And again, a big thanks to our data contributors, Matt, Errol, Felipe, Amir, and Meng from the respective sites that are listed here. We hope that this data set will be useful in your academic projects. And just to mention that this data set has been submitted for publication, like other RSNA data sets for intracranial hemorrhage in 2019 and pneumonia in 2018. If you do use this data set and its annotations in your own academic non-commercial work, and we hope that lots of people will use it, we just ask that you cite this data resource article, which should be published soon. Thank you. Just a quick note, the slides are for this talk are down below, and I just wanted to turn it over to Stephen Hobbs, who will be talking about the amazing effort around annotations of this data set.
So thank you very much. My name is Stephen Hobbs. I'm from the University of Kentucky. I'm a chest radiologist and one of the Society of Thoracic Radiology members today. So I want to take a few moments today and really thank the absolutely incredible effort that this was for the annotators. We had over 90 annotators involved with this project from 79 institutions, 18 countries, and 5 continents. And you can see the general locations really across the world. So it may be the Radiologic Society of North America, but this was a multi-institution, multi-country, worldwide effort on behalf of the annotators. All of those annotators self-identified as cardiothoracic trained radiologists, so extensive imaging experience doing this type of work every day, ensuring a very high quality data set. And those 90 annotators combined effort over 4.5 million labels as part of this data set. 4.5 million labels, really emphasizing how much work this was. On behalf of those annotators, thank you so much for doing this work. To give you an idea of how much effort some people put into this, our top annotator, Dr. Kumar, over 1,100 studies that he annotated as part of this process. And you can see here the top 10, again, not coming from a single country or a single region, again, a worldwide effort. These people put significant effort into doing this type of annotation and making it a worthwhile product, that data set, over 4.5 million annotations total as part of this data set. So from the Society of Thoracic Radiology and from the Radiologic Society of North America, thank you all very much for being willing to put your time into doing this type of work. Thank you.
Hi, everybody. So my name is Robin Ball. I'm a computational scientist at the Jackson Laboratory. And Jayshree, I'll let you introduce yourself. Well, Jayshree Kalpathy-Kramer is also here. She's an associate professor of radiology at Harvard Medical School and an assistant in neuroscience at MGH. So first of all, you've seen some labels already talked about by Chris and George. So I wanted to go over them a little bit more in detail. So as you know, we have 2 levels of labels. So we have only one label that was present at the image level, and that is for PE present. And then at the study level, that's where all the other labels are. So we have negative for PE at the study level, as well as indeterminate. So indeterminate means that we couldn't tell whether it was positive or negative due to some quality issue. But we also have other labels like location, whether it was left, right, or central, as well as severity, the RV-LV ratio, the type of PE, whether it was chronic or acute and chronic. And then if it wasn't either one of those, then the implied label was that it was acute PE, but that wasn't an actual label. And then we had different quality labels as well. We had motion, quality contrast, and then whether there was a true filling defect or a flow artifact. And this is the schematic that all of you are fairly familiar with, especially those that worked on the challenge. So we had, if the entire exam was negative, then nothing else applied. However, if it was not negative, then we checked to see if it was indeterminate, which meant that there was at least one quality label for either contrast or motion, which meant that the exam was such that the quality wasn't good enough to be able to tell whether it was positive or negative. So if neither of those were true, if it wasn't negative and it wasn't indeterminate, then that meant that there was at least one image in the study where PE was present. And in that case, then we had other labels that referred to the PE itself. So we had at least one label for location, although you could have multiple labels. So you could have right and left, or right and left as central, or any combination of those, but at least one of those had to be selected. And then we had only one label for RV-LV ratio. It was either greater than or equal to 1 or less than 1. And then also only one label for type. So this was a little tricky because it could be chronic PE or acute and chronic PE, but if neither one of those were there, it was assumed it was acute PE. So it was a little bit different there. So the annotation process went like this. So all of the de-identified data sets across the 5 institutions were combined together, and then the order of the studies were randomized. So the annotators were assigned batches of 50 studies each until the entire data set was completed. And then a small subset of those cases was labeled by all annotators so that we could calculate the inter-rater agreement. So for the training set, we had only a single annotator that labeled each of those studies. But for the test set, we had 3 independent annotators label each study. And then the consensus across those 3 annotators determined the label for the study. And then where there was not consensus or where there was any kind of incongruence, Doctors Carol Wu and Stephen Hobb adjudicated those cases whenever we needed them to. So this is the label distribution across the training set and the public test set. Across the entire data set, we had 2.3 million images and about 95,000 studies. And then in the training set, we had about 1.8 million images. About 5% of those were annotated as PE positive. And then in the public test set, we had 147,000 images and about 7,400 were annotated as PE positive. Now you'll see, looking at the distribution of the labels, that some of these were fairly prevalent, but some were not. And even like central PE, which is extremely clinically relevant, we only had about 5 or 6% of those in our training and test set. So that's something to keep in mind. Now I'm going to turn it over to Luciano.
So I'm Luciano Pribadello. I'm the current chair for the next few days, I guess, of the Machine Learning Steering Subcommittee. And after that, as John Mongan mentioned, I will transfer that responsibility to him in his very, very capable hands. I'm also the vice chair of medical informatics and augmented intelligence at the Ohio State University. And what I'm going to do here today is to explain a little bit about the significance of the results that we're seeing, that we saw with this challenge. And it brings me great joy to talk about it, but in a sense, I think this is what we are trying to figure out with machine learning, try to see whether these tools will be eventually able to contribute a lot in the medical arena and radiology space more specifically. And that's the idea behind this. It's very difficult usually with the challenges because of the combination that we do with the metric to consume that information. So I'm going to try to digest a little bit convert the metric from that log loss that we see in the typical metric of a Kaggle competition into something that we're more used to, at least on the clinical side of interpreting the results of applications such as this, machine learning for detection of pulmonary embolism. And I'll be focusing on the significance of the results from a technical standpoint, and Steve Hobbs will then talk about the clinical implications. I'm a neuroradiologist, so it wouldn't be appropriate for me to talk about the clinical significance of the PE, and he will do that part. So just to frame a little bit the importance, the clinical importance of pulmonary embolism, it accounts for about 60 to 100,000 deaths annually in the United States. It's among the most fatal cardiovascular diseases. So therefore, I think it's key, and it's one of those situations that you have to act very quickly. So that timely and accurate diagnosis is of utmost importance in providing the best care for these patients. So there's certainly a benefit in having tools that are assisting the radiologist to that task. And where do we stand today from a metric and from a performance standpoint of some of these tools, some of the research that was done in this area? So this is a paper put together, but some of the people that are actually in the committee, such as Mel Lundgren and Robin Ball, that put together this paper analyzing the performance of an algorithm created to detect pulmonary embolism, and they evaluated the performance not only at Stanford, which was where the data set was created, but also try to see if it generalized to another organization, Intermountain in that example. And they found for detection of PE was with an area under the receiver operating curve of 0.84 within the local institution and 0.85 when showing that it generalized to another organization. So the idea here is to frame how some of these algorithms have performed in the past. It's not to do a one-to-one comparison, but just to frame the problem a little more. The reason why it's difficult to do a one-to-one comparison is because there's always differences in the selection criteria of these patients, but at least it provides us a sense of how some of these machine learning tools are performing in different scenarios. This is another publication, Evaluation of Acute Pulmonary Embolism and the Clot Burden. Their approach was a little different. They created a UNet to detect and segment the clot, and their performance, the performance that they found was 0.93. Again, not to say that it was better or worse than the previous, but just because, and you can review these papers and understand a little bit better at your own time, the difference between them, because the selection criteria is very different. But as you can see, the performance in these algorithms out there is already very high. So let's see how our competitors, are in our challenge. What was the performance as far as the area under the receiver operating curve was? And so I'll start by talking about the challenge results from a patient level standpoint, actually study level. And then at the end, I will talk about the image level performance. And as Robin mentioned previously, there were several categories that were asked. And the first one, and the main question here, is whether these algorithms can detect central PE. This is really a high mortality situation that we want to identify. And as you can see here, performance. So I have the performance of the first place, the fifth place, and the 10th place. So you can expect that the other competitors, the results of the other competitors are somewhere in that range. And the performance to detect central PE, as far as the area under the receiving operating curve, vary from 0.97 to the 0.95. So remarkable performance to detect central PE. Moving forward with the right PE, which was one of the classifications to see if it really detected the sidedness. A little lower performance there, 0.95 to 0.92, but very impressive as well. LAF-PE, very similar from 0.95 to 0.93. Detection of chronic PE, this is a very difficult task. Stephen will can talk more about it, but the performance there, lower 0.86 and 0.83 as the variance for that detection. The detection of both acute and chronic PE varying from 0.87 to 0.84. Indeterminate, which was the other category that we had there, higher performance with 0.90. And as far as the clinical scenario, one very important determination is whether the right ventricle is suffering from that pressure, and it has a ratio that the right ventricle is thicker or wider than the left ventricle. So right to left ventricle ratio being more than 1. This has very significant clinical importance, and the performance of the algorithms vary from 0.93 to 0.92. As far as the image level performance, because we have, as mentioned before, thousands, if not millions of images there, the performance, that's why you see that curve being smoother and not as stair-step as previously, because the number of cases is so high, but very impressive performance at the image level, with the first place performing at the 0.99 and the 10th place at the 0.98 area under the receiving operator curve. So from a technical standpoint, as you can see, very, very impressive results, and very thrilled with how it came out. So Stephen, if you could take from here and describe how these results correlate with what you see from a clinical standpoint, that would be great.
Great. So yeah, we talked about this a little bit, but why study pulmonary embolism at all? Well, as mentioned, it is an extremely common cause of cardiovascular death, and untreated, that mortality approaches 30%. But more than that, it's also a frequent incidental diagnosis. So there are cases where, yeah, you expect to see a pulmonary embolism based off the clinical presentation or based off the history and the patient's risk factors, but it's a frequent incidental diagnosis as well, where we're not even expecting to see this as a possibility on images. And in specifically oncology patients who are at increased risk for PE, that accounts for almost a little over half of the total diagnosis of PE in that patient population. So we have to be able to diagnose it well, accurately, and we have to be able to diagnose it when we don't suspect it to begin with. Now, clinically, these get divided up into different classification schemes, but a common one would be the so-called massive, submassive, and non-massive classification, with massive being essentially a clinical diagnosis of PE in the setting of hemodynamic instability. But submassive is PE with the presence of right heart strain. And that's why right heart strain is an important thing to evaluate when you're looking at these cases, because it helps clinically classify these patients, guide treatment therapy, and guide their prognosis as well. And then you have the non-massive category, which is essentially PE, but no right heart strain or hemodynamic instability. So we need to do a timely diagnosis of this. As I said, 30% mortality if untreated, that's not good. Accurate diagnosis is very important. The therapy for this, anticoagulation, is not without risk. So we want to make sure we're giving patients the appropriate therapy if they need it. And we certainly don't want to be anticoagulating patients if they don't need it. And because of all these factors, CTA for pulmonary artery embolism evaluation is the best diagnostic test in the vast majority of clinical care scenarios. But despite this real clinical importance to getting this diagnosis right, it remains challenging for people, for humans reading these studies. Take this one example in the upper right-hand corner, a study by Seth Kligerman's group, where they looked at almost 7,000 PE studies performed over a 3-year period, evaluated how many of those were acute or chronic PE cases, and found on retrospective review, they missed 50 cases. So if you're missing 1.5 cases of PE at your hospital a month, that's too many misses. And so anything we can do to increase and improve our ability to accurately and timely diagnose these patients is very important. Furthermore, as mentioned already as well, chronic PE is actually more challenging. And I would wager that many radiologists, not just chest-trained radiologists, but many radiologists miss a diagnosis of chronic PE if that's not something they suspect to begin with. And our traditional models of PE CAD tools are pretty wildly variable effective and haven't really been adopted as a result of that. So machine learning techniques for this, like you saw before, that have a highly potential to be highly accurate and improve diagnosis and improve timeliness of diagnosis, can have a real positive impact, essentially supplementing human interpretation of these studies. So it's these sorts of tools can, if developed right and implemented well, provide a very key mechanism to improve patient care for the diagnosis of PE. I'll turn it back over now.
And next, what we would like to do is to announce the winners, the most exciting part. Kathy, are you there?
So I'll go ahead and show my slides here. So I have the privilege of presenting the awards. My name's Kathy Ambriol, and I'm from Brigham and Women's Hospital in the Department of Radiology and Harvard Medical School, but I'm also the Director of Research at the MGH, Mass General Hospital, and Brigham and Women's Hospital Center for Clinical Data Science. I'll remind you that the awards for this year, a total of $30,000 have been in prizes, have been jointly provided by Kaggle and the RSNA. And what we're going to hear now are the top 10 performers in reverse order. So for number 10 was Or Katz. He's at NEC Corp in Israel. Number 9, Naota Shimakashi and Rin Sato from Mobility Technologies in Japan. Number 8, Jan-Peter Bremer, Yuji Ariyasu, and Taki Sugiyama. Jan is a medical student in Hamburg, Germany, and Yuki and Taki are data scientists in Japan. So you can see the international activity that is involved in this challenge. Number 7, Yuval Riena from Defend in Israel. Osamu Akiyama, who's a resident physician at Osaka University Hospital in Japan, was number 6. Number 5, Darrell Hanley, who's with Doubleyard and also teaches in the master's program in data science at University of California, Berkeley. Number 4, Kazuma Matsuura, who's with Ricoh Company in Japan. Number 3, Dat Go and Dongwen Ba, who are with Deep Kappa AI and Vingroup Big Data Institutes. Number 2 was Ian Pan, who is currently a medical intern at University Hospitals in Cleveland, and he'll be a diagnostic radiology resident next year at Brigham and Women's. And our top performer was Guanshu Zhu from H2O AI. So can I just say that from the committee and all the evaluators, this was an incredible group of submissions, and congratulations to the top 10 performers. In addition to those top 10 performers, this year, the committee decided to present an Educational Merit Award. And this was done based on the additional submissions that the top 10 performers submitted after they were deemed winners. And they provided discussions about how they approached their solution, their architecture, they created a video, and so on. And we had judges review and score each of the top 10 submissions for each of the following categories: clarity and comprehensiveness of the explanation of the approach that was taken by the entrant, the clarity, accessibility, and organization and architecture of the code, the estimated effort required to run the code, that is, can we reproduce the results by retraining and run inference on a new data set, ease of reuse and repurposing of the code, the novelty of the approach, and overall educational value of the entry. And I think I can speak for the judges that we all learned quite a bit from all of these submissions, and we feel that there is a tremendous educational value to these challenges, and you see the folks helping each other in the competition and providing different types of programs and so forth for everyone to learn. And so this is why we wanted to recognize an overall educational merit award. And that goes this year to Ian Pan, who again is a medical intern at University Hospitals in Cleveland and will be at BWH next year. So really, really blown away by the quality of the submissions and all the entries, and congratulations to all.